Thank you, Joe, and thanks for being here, everybody. This is a great opportunity for me to speak to a lot of folks, and maybe many of you are non-healthcare folks. So how many of you have a healthcare background of any kind? Oh, quite a few. Well, good. So you can help me out. I'm going to try not to use all the acronyms that we use in healthcare. How many of you think the healthcare system needs to be transformed? And how many of you think it's sustainable in its current form? Nobody. Good. So we have a lot to talk about because it's a very complex industry. We've been doing a lot of work in the industry, and we have decided that the idea that 5,000 or 6,000 hospitals and thousands of doctors and other non-acute care sites all deciding how to fix this themselves, all spending the money over and over again to reinvent this, is probably not the most effective and most efficient way to do it. And so I don't know how many of you know much about Premier and who Premier is. Premier is this alliance with a 40% footprint. The thing that makes it a little bit more interesting is we actually have clinical data and operations data on the hospitals that are a part of the alliance. And we are bringing this idea of scale and aggregation to the alliance. So, for example, we help them buy $43 billion of supplies, drugs, medical devices, capital equipment that's used in healthcare systems. The idea that we could use that same power of aggregation and power of scale to get them to transform how care is actually delivered is the thing that we've been working on for many years, and I want to talk to you about that more today. So what's the problem? The problem at its very core is that the rate of growth in Medicare and Medicaid, which takes care of old people and poor people and huge populations in this country, is growing at a rate that's 1 to 2.5 percentage points faster than the GDP. And if you look at those little numbers on the right-hand side, that's what would happen to your tax rates if we continued to have this kind of a growth rate in Medicare and Medicaid. Your tax rates would have to go from the 10, 25, and 35 to the 26, 66, and 92% if tax revenues were the only way to fix this problem. So that's a very politically unpopular idea. So the idea is that we have to fix it in another way. So the question is, well, what's really wrong? Dartmouth did a study many years ago, sort of a famous study, that looked at even if you price adjusted the cost of health care for a Medicare beneficiary across this country, even if you price adjusted for local wages and things, you would see huge variation. And don't focus even on the numbers, which you probably can't read, but just look at the colors. The variation in the cost of a Medicare enrollee per year ranges from $5,000 to $15,000 depending on where you live. And it doesn't have to do with price and local differences in wage. If you look then at some of the chronic conditions like asthma or diabetes or COPD, you see a similar variation, a very big difference between how the 10th percentile and how the 90th percentile performs. And the question is, what is at the root of all of this variation, and how much of it is justified and how much of it is unjustified? And if you could figure that out, then how would you actually go about implementing the changes to improve it across the country? So if you think about our environment, people many years ago decided that our environment was also unsustainable if we continue to overuse certain parts of it, not innovate around it, not behave differently. And there was a study done back in 2004 that actually identified and put a calculation on the unsustainability of the environment. And then what they did was they said, well, let's identify the wedges, if you will, that if we made changes in those wedges, it would close the sustainability gap. What's happening in healthcare now under the leadership of Don Berwick at the Center for Medicare and Medicaid, and also largely due to some of the health reform initiatives there is an attempt to try to identify these wedges of sustainability, put a price tag on it, and then go about driving the improvement across the country. And if you think about what the wedges are, you might be surprised. Actually, people in healthcare are a little bit surprised that the biggest one is administrative cost. Because Medicare and Medicaid and all the commercial insurance companies all have different forms, all have different measurements, all have different levels of automation, all have different levels of manual activity, and it creates a huge cost just because we don't have standardization in the system, standardization of measurements, standardization of forms. The second thing, and it only takes folks about 90 days of going to work inside Medicare and Medicaid to decide that there's a huge fraud and abuse problem. There are a lot of people working the system. It happens to be in certain geographies of the country, but a huge price tag on what we call fraud and abuse. And if you think about fraud and abuse, it's a wonderful political platform because you can talk all day long about how you're going to cut fraud and abuse. The third thing is a tougher one, and this is the concept of over-treatment. Overutilization of healthcare services, lab tests, duplication of tests, imaging, diagnostic imaging, the use of intensive care units. I mean, there are so many pieces to this thing called overuse, most of which the general public doesn't understand, and most of which patients might say, I want to get everything I can get, and if I have to do a test 2 or 3 times, doesn't matter if it might help me solve the medical problem that I have. And so we have a little bit of misexpectations run wild. We've got advertising on TV. We've got very little accountability in the patient for one, his or her own health, and 2, the financial responsibility for the costs of healthcare. So overtreatment is a big wedge. There's another big wedge called system failures. And this is all the times that people are harmed, medication errors, falls, not following the evidence, all the things that happen in a system where failures occur. And unfortunately in healthcare, this failure rate is significant. And you can, I bet if I polled the audience, almost every one of you would have a story about something that happened in a healthcare experience in your family or with you that represented a failure of the system in some way. Prices, interestingly enough, is one of the wedges, but it's one of the smaller wedges. So this may not be about the unit price of healthcare, it's about how all these other things get added together. The variation, the overusage, the administrative costs, the fraud and abuse, and the other things. And the last one, and this one I think is probably bigger than the number would indicate, and it's this problem of fragmentation in healthcare. You are largely responsible for navigating your own coordination of care. The doctors and hospitals and nursing homes and home health agencies aren't very good at coordinating that care. And consequently, it ends up causing more errors and it ends up costing more money. So that's the problem, and those are probably some of the big wedges that we can use to fix the problem. So what did reform try to do? What did the legislation try to do? I think it was very intentional, and whether you're Republican, Democrat, Independent, or anything in between, I think the design of the reform legislation was to make it so painful to stay in this fee-for-service where providers are paid for every single thing they do, whether it's over and over again or not, to make it so painful to stay in that track that healthcare delivery providers would want to innovate, would want to do this a different way, would want to experiment with new models of care delivery. So if you go through the legislation, there's a whole bunch of things in it that cut payments. They cut payments at unit price, they cut payments for anything that they could deem preventable. So it might be preventable mortality, it might be preventable readmissions back into the hospital, it might be preventable harm that happens in hospitals. They basically said we're not going to pay for anything preventable. and we're going to pay you based on your performance. So we're going to start measuring and comparing you, providers, against others that start to pay differentially based on your quality, your safety, your outcomes, your harm, your mortality, all those things. And at the same time, they funded $10 billion in this thing called the Innovation Center. You might have been reading a little bit about it lately because the Super Committee and others are starting to question, given our economic condition right now, do we really have the money to spend on innovating the care system? The problem with just a purely cut strategy is when you cut, you just take things away from people. That doesn't tend to work really well. What you really have to do is fundamentally change and improve the system. So these things called accountable care organizations and these things called bundled payments, which are now initiatives coming out of the Innovation Center, are really designed to help us experiment, build, test, and scale new models so then they can be put into policy. I spend 50%, 60% of my time on the road all over the country with our healthcare organizations, and I spend another 30, 40% in Washington, D.C. And way back when the legislation was being contemplated, one of Obama's advisors said to me, we really need a model that's predictable, that is a global payment of some kind that we can give to somebody, and they will take responsibility for managing with you your health care for your life, especially for Medicare and Medicaid recipients. He said the problem is we don't have anybody to give that money to. Nobody trusts the government to make clinical and economic decisions. Nobody really trusts insurance companies completely to make clinical and economic decisions. We actually want providers with patients to make their clinical and economic decisions. But we don't have any organizational structure or business models that actually allow us to give that money to somebody to manage it in a more predictable way. So that's what the Innovation Center is designed to do. So if we move on, I'm having a little trouble with the remote. There you go. So this is the current state of our healthcare system. Very little dollars are spent on the bottom of the pyramid in preventive care and health promotion. And as you go up the scale, more and more money is spent on non-acute and specialty care and then really intensive care. And so the current state is it's volume incented, it's fragmented, it's not connected with technology, it's high cost, it's a focus on sickness, it's opaque, there's not a lot of transparency in the system. And so what we need to move to is the future state, which says we're going to spend a lot more money on primary care and preventive care, and therefore we'll have to spend maybe less on this more specialized and intensive care, and we're going to connect data, and we're going to use e-commerce, and we're going to have accountability and transparency. And so the challenge for healthcare systems and for payers and for consumers is how do we get from here to there. We actually a few weeks ago we tried to get as many different opinions in the room as we could, and we brought 50 or 60 people together, and they represented every perspective: employers, health plans, consumers and patients, hospitals, doctors, government agencies. We had every opinion you could imagine, and we said, if we don't like the way the current system actually measures its success, how would we measure it differently? And we locked ourselves in a room and we said, if we were going to measure it differently, what would it look like? And this is what we came out with. And it was very simple, which was if you and me and you could say that on an annual basis, I as a patient or a consumer would report, and I would report it, patient reported, the number of healthy days per year that I had, plus the care experience I had when I had to access care, divided by total healthcare expenditures, which means my portion of the premium at work, my out-of-pockets every time I go, my lost wages when I'm out sick, all the forms of healthcare costs. If we could, as a country, figure out how to get the numerator right and how to get the denominator right, we might actually make an impact on healthcare costs and quality in the country. So the question is, how do you do that? And I know this is a complicated slide, but since you're all a bunch of operations research folks, you'll love it. The question was, how do we build measurement that actually incents the right behavior? And on the inside, if you will, of the customer, the patient, they want to measure their health, they want to measure the cost, and they want to measure the experience. But it needs to reflect engagement with patients, and it needs to reflect trust, and it needs to be simple, and it needs to be financially sustainable. So then the question is, how do you go back to the delivery system and measure them in a way that actually is going to deliver on that promise to consumers? And that means you've got to have the technology. You've got to measure those same things, but you've got to have all the infrastructure, and you've got to have all the ways to take that very high-level measurement and peel back the onion so that you can measure the different parts of the healthcare system and have it work to get to that ultimate outcome. So how do you do it? So what Premier's done is we've said, okay, we know what the problem is. We know it's not sustainable. We know what the wedges are that we need to improve. So how do we mobilize this 40% footprint to go after it, to really make a difference? And the belief we have, and this has evolved over time, we didn't have this belief when we started because we didn't know what we didn't know. But the belief that we have is the first thing we had to do was to get some of the fundamental process right. So that if you ever have a heart attack, you can be confident that you're going to get every single thing every time that the evidence would suggest that you should get. And we didn't have that experience in this country. In fact, when you looked at evidence-based care for heart attack or for knee surgery or for other clinical conditions, we had about a 50% compliance with what we call the perfect care bundle. Okay? So the first thing we said we have to do at its very basic level is get, where the evidence does exist, people to 100% compliance with that evidence. The second thing we learned, though, along the way was that's not actually enough, because those are process measures. What we then have to be able to do is prove that the outcomes are effective, that they're actually implementing those processes are making a difference. And where you don't have scientific evidence that takes 17 years to get 95% adoption, what do you do in the meantime? And what do you do with clinical opinion? And how do you experiment with things, and these are people's lives, right, that yield better outcomes for the system? And then beyond that, it's about how do you actually improve the health of the population so they don't need to access the system. So we began to see these sort of three distinct levels of transformation that have to occur. Let me go back to this one. If you think about that in the context of healthcare reform now, it also seems intentional that the healthcare reform legislation contemplated this evolution of payment models to go with the evolution of care delivery. So the evolution of payment models was, let's start moving away from paying for volume and start to pay for performance, this thing called value-based purchasing. And then let's move from that into some very focused areas where we've got failures of the system. And that would be every time you're harmed in a health system, or every time you have to go back to the hospital because something happened after you went home that shouldn't have happened. Let's focus there. And then let's focus on, let's start to bundle payments. Maybe we can't get to the whole thing all at once, but let's just put hospital and doctor payments together first. And then let's experiment with this thing called a medical home, which is a primary care doctor, your family practice doctor and nurse practitioners in his office, wrapped around you as a navigation system to help you figure out where to go and what to do and what you need. Then let's move to risk kinds of payments, and then let's move to global kinds of payments. So I think there is some method to the madness, and I actually think that the logic of it kind of works, because it's not going to be easy for us to go from being paid in the healthcare system based on everything we did to being paid based on the outcomes and the health of the population. And so we use this collaborative methodology where we actually try to identify the problem, go find a group of willing innovators, people who will step out there, and I've about decided it only takes 10 or 15% of our membership in any one of these experiments to figure out what works and what doesn't work, and then to move it into higher and higher levels of performance, and then move it into policy. But get the group that's willing. Some things we've learned about what's absolutely critical is, one, that they agree to be transparent, and that's harder than you think. They agree to be transparent. They agree to measure things in the same way. One of the problems in healthcare today is we don't even know how to define high performance. We measure it in all kinds of different ways. So they have to agree on the measurement, agree to be transparent, agree to do the work, agree to share their best practices with each other, agree to learn from each other, agree to continue to measure it, and agree to take it down inside their organizations at all levels. And when we do this over and over again, it's clear to us the minute we say we're going to measure it and it's transparent and we start sharing best practices, the numbers get better. They continue to get better for the whole time that we do it. So that's our belief. These are some of the results, and I know it's probably hard to see. Just look at the colors and look at the starting points, which were pretty low on some of these, and look how the compliance improved. And this is the one that measures if you have a heart attack or if you have knee surgery, what percentage of the time do you get everything you're supposed to get based on the evidence? And it went from what started in sometimes the 50, 60, 70% range up to 95, 98, 99% levels of compliance. So if you're building, testing, and scaling, I talked about this a minute ago, it really is how do you do this in sequential steps? How do you publish this nationally? How do you get payers starting to look at this? We now have the state of Hawaii who came to us and said, you have this measurement system. It looks like you've got a couple 100, 300 hospitals who've agreed to it. We, the Blue Cross plan in Hawaii, which is a full access to care state, want to take that measurement system and we want to pay all our providers in the state based on that measurement system. And so we want to hold out 5, 6, 7% of increases in health plan costs based on the performance against these measurements. And I think you'll start to see more and more adoption of what becomes standard measurement systems. So if you're a patient, put your patient hat on again, or your family hat. I'm a mother and a grandmother, and I've got a huge extended family. What do you want from your healthcare system? You want the healthcare system to keep you out of the hospital. You want the healthcare system to actually know you, understand you, tell you what the options are, tell you what it's going to cost, tell you when it's going to be clinically effective or when you don't know whether it's going to be clinically effective. You want your information connected so that if you have to go from one place to the next, the information is connected. You want to be able to see your own information. And you may or may not want to be accountable for your own health. So you need somebody to help you, push you, remind you, alert you, and try to help you do the right thing. So we took all that, we said, if we keep the patient in mind, and we take this delivery system, how would the delivery system improve itself? And what we said is that it would measure from an outcomes perspective how it did on cost, and oh, by the way, we want it not to bankrupt us, right, as patients. How would it perform on cost? Would it follow the evidence, give me everything I'm supposed to get for that clinical condition? It wouldn't kill me if I wasn't supposed to die. It wouldn't harm me and have something bad happen while I'm in the healthcare system. I'd be treated kindly and with care, and I'd have a good patient experience, and I wouldn't have to go back to the hospital after I went home. And so we decided for 300 hospitals to measure all 6 of those dimensions at the same time. And it wasn't going to be good enough to be good in 1 or 2 or 3 of these. We actually said we want to get 50% of the cohort to top performance in all 6 of these dimensions at the same time, because that's what a patient might consider a high-performing healthcare system if you had to attach to a healthcare system. So we now have, I think, almost 300 hospitals, and the test was, does that measurement system work everywhere? Does it work in academic hospitals? Does it work in small, rural, critical access hospitals? Does it work in New York City? Does it work in California? And so we wanted a good sample size. The first couple of years, 2.5 years, we were able to measure the first 3 dimensions. And what we saw was pretty remarkable. So the evidence-based care, that's the, do you get everything you're supposed to get every time? By the end of 2.5 years, 97% of the cohort was at top performance. In observed to expected mortality, we saw a 27% reduction in mortality. That means people's lives. It ended up being 25,000 lives. We saw a $900 per case decrease in the cost per case. And this was just with very early focus on how do you make these improvements. So if you then look at harm, what do you think we learned about harm in hospitals? The blue line now is these Quest hospitals, the ones who are the innovators in this group. The green line is everybody else. So what happened with harm? It went up. Because guess what? Nobody was measuring harm at all. And once you start looking for harm and measuring it and documenting it, you find it. And that raises the discussion of harm. And then you have the question of, is it a penalty system for harm? Or is it a system where you try to really drive improvement so harm declines over time, and you do that by opening it up? And do you apologize to patients? Or do you sweep it under the rug? Or do you figure out how to really change the system? So this whole harm thing raised all kinds of questions and issues and potential liability and other kinds of concerns, but you can't fix the harm problem unless you know what it is and where it is. What about patient satisfaction? This is what we call a turnip plot, and we plot the baseline for our membership, and then we set a top performing threshold. So patient satisfaction is what percentage of you would give your health system a 9 or 10 on a scale of 1 to 10, a 9 or 10 in your overall satisfaction with their system, or your loyalty to the system, your willingness to recommend it or to return. And the bad news for patient experience is there's not a lot of variation. It's just all bad. When top performance is defined as 74%, then you know you have a problem, right? In terms of the care delivery system and the customer satisfaction with it. So a ton of work needs to happen here as health systems in this highly complex, fragmented system try to care for patients and spend the time. And remember, this is all being done while all those cuts are occurring. And when cuts occur, what happens? Jobs go away, time gets stretched, productivity has to increase. So as you can see, we're kind of building to a big challenge. The thing that the folks in Washington, so they look at all those other charts and they say, that's great, that's great. This is the one that they say, now we're getting somewhere. Unfortunately, cost is a big focus up there. The green line is the healthcare cost over the last 2.5 years. Inpatient hospital cost has grown 21% over the last 2.5 years. The red line is the Quest hospitals, these innovators, and their costs have grown 4%. So it is true that the cost curve can be bent. It is true that with effort you can really make a difference in cost and quality and safety. The funny thing is that we haven't gone directly through the cost door. We've said if you prevent mortality, if you prevent harm, if you follow the evidence, if you treat patients well, if you don't readmit them to the hospital, cost will go down. And they in fact have gone down. Okay, so then we had a realist evaluation. We had Dartmouth come in and say, we really need to study what it is about this that caused improvers to be able to improve and people to be able to sustain the improvement. It was a lot of things. It was all the way from the boards of health systems actually measuring their C-suite based on these metrics, all the way down to the front lines, the transparency of the results posted in every nursing unit. There was actually something about pace, something about momentum, which is if you measure in increments and people feel good about the improvement, that you can maintain a pace of improvement and people just don't get worn out with the improvement initiative. We also found that there had to be performance improvement methodologies inside. Real infrastructure, real technology, real benchmarking capability, real collaborative infrastructure so people could share best practices, but that it didn't necessarily matter which method was used, but just that there was a method used inside these organizations. So now we have a couple of more collaboratives which start to get a lot harder. The leap is bigger because health systems within the four walls of health systems can actually work on all those things I just talked about. But once you start saying, we're going to improve the health of the population in Charlotte, North Carolina, it becomes a lot broader. And the idea here, and this is the idea behind these accountable care organizations, is that at the center of this healthcare system in the Charlotte community would be patients. And around me as a patient and family, I'd wrap a medical home. That would be my internal medicine doctor or my family practice doctor and all the pieces and parts that go with that. They would help me navigate specialists, nursing homes, surgery centers, imaging centers, and around that you'd have a wrap of technology and population-based information. The problem we have today with the system is that health insurance companies have data that's very wide but not deep, so they know everything you've had across all the different providers, and providers have very deep information, clinical information, and those two things have not been put together very effectively. So the idea is you build the data capability to do that, and you build a legal structure and an incentive set of models. You have to deal, this starts to raise lots of other questions, like if a system like that gets built, does it create a monopoly? Does it create an all-enclosed system that then becomes non-competitive and price points go up? So you've got FTC concerns and all kinds of other concerns. And you've got these groups of providers who have all been pretty siloed for a long time. So the trust issues and the partnering issues and the relationship issues and the transparency issues are very real. And there are examples around the country where it's working. We actually now have two collaboratives. One, and we call it the Partnership for Accelerating Care Transformation. You can see we got hundreds of hospitals, again, geographies. But look at this. We've gone in, we'll skip that one. We've gone in and assessed all these, clicker is a little, there you go. We've assessed these systems. On the left-hand side, when we have built a capabilities assessment, which is we know what the 150 capabilities are that you have to have: technology, people, process, all the capabilities you have to have in all the dimensions of really being an accountable care organization. And we've now assessed the members of these collaboratives against those capabilities. The left-hand side is the people who say, I am on my way, almost ready to be an accountable care organization. But look at the variation in their capabilities, from the red being very few to the blue really being able to have a lot of the capabilities needed. The right-hand side are the ones who would admit that they're not there yet and have a pretty long way to go. So again, the challenge for us as a country is we've got all these health systems, varying degrees of sophistication, all kinds of disparate IT systems, and yet we're trying to build in local communities these sustainable care delivery organizations. So that when I go to Carolina's healthcare system, and Carolina's is actually way far along in this, but when I go to Carolina's healthcare system, I can go to my primary care doctor, I can put my hand in a palm reader. That palm reader knows all the information about me and my drugs and everything I've done and everything I've had, and by the way, can know that on my whole family. I receive the treatment, they do the annual testing, they send me wherever I need to go. They give me a little piece of paper that says if I want my health online, that I can interact in a social way with my own healthcare information. And so they're starting to build those pieces that could become accountable care organizations. Lots of things missing, and I want to focus here because I want to leave a little bit of time for questions. Lots of things missing. This was why we did our IBM partnership, because one of the things that was missing for healthcare providers is data across all payers. So what happens today is you get information exchange with Medicare and Medicaid, you get information exchange with all these health plans, and it's all different. And so and most of the healthcare providers would tell you, and most patients would say, we don't actually think it's right for patients to be treated differently clinically based on who their payer is. We should be delivering medicine in clinically effective ways to all patients. So we did this partnership with IBM so that we could get all payer data into the system, and we could link that data and start to get to population-based healthcare. So we know it works. And we know it works because some of the folks that are participating in these collaboratives have done some test cases. So this is Atlanticare, which is in New Jersey. Atlanticare came into this accountable care collaborative and they said, we're in a depressed economy, we have casinos and we have unions, and those are our partners, and we want to figure out how to lower the cost of healthcare and how to improve the clinical quality of healthcare in our geography. So they took these high-cost populations, and these populations cost 4 times the average, and they said, we're going to pull these populations out of this fragmented system that we have today, and literally, they set up a conference room. They set up a conference room with 10 people off-site of the healthcare system to manage the chronic conditions that these patients had, and to go out to the patients and to interact with them by telephone. So they used a conference room, table, chairs, telephone, and computers, right, to manage this population. They said, we want to get to top decile in chronic disease management. We want to get a 10 to 25% reduction in costs and utilization. We want to get 40% reduction. We want to keep these people out of the emergency room because that's where they were all going. And we want a 20% improvement in the care, or 2 times, improvement in the care experience scores. So after a very short time, here's what they started to see. First, they got 63% of their patients to stop smoking. Okay, not something that actually happens in a hospital, right? It happens outside of the hospital. They got patients to actually fill their prescriptions and take their drugs 97 to 99% of the time. Health plans will tell you the number one problem they have is prescription compliance, and the underlying problem that drives that is depression. Because when people are depressed, they don't take their medicine, they don't go refill their prescription, or economic problems and they cut their pills in half because they can't afford the drugs. So then here's some other clinical metrics. 30-day readmissions. That means did you have to go back to the hospital within 30 days, dropped to 4 or 5%, when industry norms would be 10 or 12%. And you can see significant drops in hospital admissions and emergency visits. Now take all of that and tell me, what do you think happened to the revenue stream of Atlanticare? It went down. They didn't have the hospital admissions. They didn't have the outpatient procedures. They didn't have the ED visits. And when you're paid based on volume. So we're asking these healthcare systems to innovate and make these changes along this path to a better future. And I had one CEO tell me that he had been doing all this work so that he lost $20 million in revenue, which went straight to $20 million lost on the bottom line, because a lot of costs in healthcare are pretty fixed. And his board was saying to him, tell me again why you're doing this and why this makes sense. And so there are a lot of big bets being placed that actually that future is going to look like what we think it's going to look like. Because otherwise these people are making very bad economic decisions in the short term. So, just in closing, I think there is a path forward here, which is to build, test, scale, and move it into policy. I don't think the time frame has to be 20 years. I actually think from all of our collaborative activity, we've learned that in about a 3-year period of time, you can know what the measures are, you can transparently measure it, you can build the automation you need to actually get what you need, and you can share the best practices and really see the improvement. So, in my opinion, in a 3-year time frame, you pretty much can know what's working and what's not working. And so probably can move it into policy and regulation at that point. That's a generalization that may not hold true for everything. But the key is you got to have the data, you have to have the transparency, you have to have the willing, you have to have cultures in those organizations that really push forward the improvement. You have to share and have them share best practices. And I don't think it works in some ways if you don't somehow take it into the practices of insurance companies or the practices of the government in a policy way, because the problem we have right now is it's a cottage industry and everybody's doing work like this in different ways, but we can't prove anything because they're all measured in different ways, and we need to get to some standardization. So I'm going to stop there. Premier is really on this road. We call this our sunshine or our sunset, a road to the sunset, which is we have to link clinical information, cost information, harm and safety information, productivity information, and we have to wrap collaboration around that and really use the collaborative power to transform the healthcare system. And we need to be informing the folks in Washington who don't have the real practical application experience of some of these changes along the way. So I'm going to stop there. I think we've got runners with mics, and happy to take any questions or have you offer any opinions or disagreements or anything you want to say.